And so let's go over a couple of questions before we have the next speaker come up. All right, the first one is a 19-year-old asymptomatic male who presents for further evaluation on baseline ECG, which demonstrates intermittent pre-excitation at a heart rate of 57. What's the preferred approach? An EP study to risk stratify, initiation of beta blocker, an exercise stress test, a Holter monitor, or reassurance? Okay, we have some divergence of opinion. Atrioesophageal fistula following AF ablation typically present 1, within 24 hours of the ablation, 2, on post-op day 3, 3, 1 to 4 weeks later, 4, 3 months later, or 5, at any time post-procedure. When do you develop these awful fistulae? Never if Dr. McLeod is the operator.
We hope.
Okay. Which of the following antiarrhythmic approaches should be avoided as therapy for a 59-year-old woman with no structural heart disease and persistent symptomatic AFib? Which should be avoided? Amiodarone, difetilide, flecainide, dronedarone, or propafenone? It's a good thing we have a lecture on these things. So, I want to welcome Dr. Chris McLeod. Chris is an electrophysiologist with particular interest in the arrhythmias associated with adult congenital heart disease and hypertrophic cardiomyopathy, but all things heart rhythm related. He recently moved from Mayo Clinic Rochester to Mayo Clinic Florida. I think the beach had something to do with that. But we're glad he came back to give us his wisdom today. Chris, thanks for being here.
Thanks, Steve. Hi, everyone. So, SVTs and atrial fibrillation, I really want you guys to get this well, get them all right on the boards, and it's just such important stuff for arrhythmia management, for general cardiology. These are the things that you see the most of, and it's nice to have a good, cohesive approach to all of these patients. So when we're speaking about SVTs, you're going to have to think about them in these two frames. The first is, how do you manage the patient in the emergency department who's in an SVT, tachycardic, and then there's preemptive chronic suppression of that arrhythmia so that this doesn't occur, avoiding the episodes. There are also some new guidelines out now. They came out 2016, and I think probably would start to come onto the boards either this year or next year. And I think they do a fantastic job of distilling down concepts which there is probably very little data for, but it's a nice cohesive document, and I've labeled that at the end of the presentation. But really, to stop rapid SVT acutely, cardioversion, reserved for those people who you can't stop with adenosine or IV AV nodal blocking agents, or if there's any hemodynamic compromise. So class 1 indication there. And then obviously vagal maneuvers, even though they're so less likely to be effective, it's still very safe to try that. And obviously adenosine, blocking the AV node, just as Dr. Madhavan showed you, is such a core element in the reentrant tachycardias. So AV node reentry, accessory pathway mediated tachycardias, if you can block the AV node, you're going to terminate the tachycardia, and it is nevertheless still benign if there's an atrial flutter or an atrial tachycardia going on behind there. So very safe approaches, and class 2 recommendations for the drugs, IV diltiazem, IV beta blockade. I guess the real concern with those is you're going to drop the blood pressure too, and it may already be on the low side with tachycardic SVT. Chronic suppression, vagal maneuvers, class 1, just because they're safe. They work in practice at around 5 to 10% of patients long term. And then this is a nice change to the guidelines for the 2016 guidelines. If there is no pre-excitation on the ECG, then you can consider as suppression AV nodal blockers like diltiazem, verapamil, any other beta blocker. Because as you probably know, and I'll show you some examples of this, if you block the AV node when someone has an accessory pathway, you're going to force conduction down the accessory pathway. And if there is atrial fibrillation, which is common, you can translate atrial fibrillation into ventricular fibrillation. These accessory pathways typically do not decrement like the AV node. So 300 beats in the atrium will become 300 beats in the ventricle if you block the AV node. And then ablation really is a go-to treatment option. It's become so safe and so perfunctory in the child or even the 96-year-old with sustained tachycardia. The success rates really should be in the high 90s. We tell our patients here 95% and higher, and safety, very unlikely that you would have some kind of catastrophic complication with an SVT ablation. The class 2 recommendations, I think, are more difficult to test on, especially the things like the class 2B, and there is some data for dofetilide and sotalol and even amiodarone for patients with sustained or recurrent SVT who aren't candidates for some of the other treatment options, but really going ahead with ablation or AV nodal blockers should be your first-line therapy. And just reiterating that point on ablation, it is so successful and so safe, no matter who the patient is, reasonable to take them to the lab to study the SVT, see what it is, and if you're there, ablate the SVT. So this is getting to that point of blocking the AV node if someone comes into the emergency department with a rapid SVT. But this is pre-excited atrial fibrillation. So this is a wide, complex, irregular SVT. So this is atrial fibrillation in this diagram here going on in the atria, and it's conducting both down the AV node and both down this left lateral accessory pathway. So you've got varying degrees of fusion. The narrow complexes are all coming from conduction down the AV node. The wide complexes are when the AV node blocks, and it goes down the accessory pathway. So if you block the AV node, that could be potentially lethal. So here's an example of where this was actually done. You can see rapid, pre-excited atrial fibrillation with varying degrees of fusion. And then as adenosine is being given, you can see that the heart rate in the ventricle, the ventricular rate speeds up and becomes very, very rapid here with another push of adenosine. So really potentially lethal, and this is a new class 3 recommendation, not just for adenosine and pre-excited atrial fibrillation. You don't want to block the node with any of these agents. So the treatment for this type of arrhythmia is going to be procainamide, is probably the board's answer. Ibutilide does such a good job at blocking atrial fibrillation. It doesn't do anything for conduction down the AV node, that it can terminate atrial fibrillation very rapidly in these patients. So either of those in practice would be very reasonable to use. So that's pre-excited AFib. And then taking a step back to what you do about risk stratification for these patients with WPW. So they have a delta wave on the ECG. 70% of these patients are going to get tachycardia of some form, and most of them are going to have, as Melanie showed, ORT or ART, where the accessory pathway is participating in the mechanism. A third, and we don't fully understand the reasons behind it, are going to get atrial fibrillation. Interestingly, if you ablate the accessory pathway, the atrial fibrillation goes away. So those are patients with symptoms from their accessory pathways, WPW. And this is what one should start thinking about if they have those symptoms. And risk stratification really needs to be broken into these two groups. Symptomatic patients, so they've come to you even if nothing's recorded. Well, I felt like I was going to pass out, or my heart's racing frequently. Even if you don't have documentation, you really are obliged now to pursue risk stratification. And the guidelines make a big deal, and it gets to that question I was asking earlier about one particular thing. How well does that accessory pathway conduct? They have different conduction properties. And if you think of an accessory pathway that doesn't conduct very quickly, there's no way that that patient is ever going to be at risk for ventricular fibrillation. Because if it blocks at 70 beats a minute, it can't conduct AFib down to the ventricle and cause VF. And VF from pre-excited AFib really is the only thing that we worry about in WPW. That's sort of the sudden death risk issue. So if that pathway is not functioning very well, it's never going to have that potential or that risk for that particular patient. And so if you see an ECG where there's intermittent pre-excitation, meaning just on a Holter or a stress test, heart rate is getting up and that pathway starts to block, you then know it's never going to be a dangerous phenomenon for that patient. It's going to be just an ECG curiosity. But if patients have symptoms, exercise them or Holter, looking at that pathway conduction property, and that's exactly what we do in the EP lab. Now the asymptomatic patient, delta wave recognized serendipitously on an ECG, and they've never complained of any other symptoms. So this would be also just looking at the pathway conduction properties. We would call it a low-risk pathway if there's abrupt loss of pre-excitation on an exercise stress test. Also, as I said, on a Holter, if you see that the pathway is not conducting, it's not robust enough to conduct atrial fibrillation to the ventricle and cause VF or sudden death. But it's also reasonable to risk stratify these patients. This is a 2A if the patient is concerned, if the parents are concerned, because we don't fully know what's going to happen with that pathway over time, even if they are asymptomatic. Ablation is reasonable if the accessory pathway will conduct rapidly, and if employment is precluded, like a pilot or a bus driver or something like that, someone working on a high building. You don't want them to go into a dangerous rhythm. But this is also new in the guidelines that because the risk of sudden death is so low from atrial fibrillation translating into ventricular fibrillation, it really is reasonable in this asymptomatic group to observe these patients. You don't have to. So it's going to be based on you discussing that with your patient and their family, what you want to do about this. Obviously, if you have documentation of something more malignant, then that makes it more easily. So let's move to AFib treatment then. These are the two questions you should always address and document with your patients. So what are you going to do about the rhythm itself, atrial fibrillation? Are you going to slow it down, or are you going to aim for an antiarrhythmic approach? And the second, as Dr. Madhavan was alluding to, and this is by far the most important from a quality perspective for electrophysiologists and for hospital-based practice, have you discussed anticoagulation with your patient? So if one looks at rhythm versus rate control in different types of patients, we know from those early studies from AFFIRM and Hot Cafe where they randomized patients to a rhythm control strategy versus a rate control strategy, there was no real difference in hard endpoints. Stroke, mortality weren't changed, and there was even less hospitalization if you decided to embark on a rate control approach. So certainly then, it's making the case that we should reserve rhythm control for a particular subgroup of patients, and those are the symptomatic patients. Symptoms dictate an antiarrhythmic approach by and large. There are a few caveats here, and that study, or those studies that were done in the 1990s, catheter ablation was not part of that randomized strategy for antiarrhythmic management. The average age was 70 for all of those patients, or in that group. And so what do you do with a 41-year-old with paroxysmal asymptomatic atrial fibrillation? Do you just leave them in AFib? We don't have all the answers based on those trials. And that's going to be a more difficult sort of patient-centered, individualized approach that you're going to have to negotiate with your patients. And anticoagulation really was not very good at that stage, at least in the AFFIRM trial. It was interrupted by and large quite a bit. Catheter ablation data, where the catheter ablation reduces stroke, we don't have that. The Cabana trial is designed to answer that, and that's going to be, it's finished enrolling, so hopefully in the next 18 months we'll have some data on that. But I think this is a nice schematic for your practice. If they don't have symptoms from the atrial fibrillation, then you can move ahead with rate control. If you're unable to slow down the rate, then you are going to have to move on to a rhythm control strategy. And also, if they're failing rhythm control and they're failing rate control, AV node ablation is acceptable. And this is also part of the 2014 guidelines. So rhythm control then, if patients are still symptomatic despite controlling their heart rates, there are some patients who are just very sensitive to the lack of AV synchrony, and even though the ejection fraction has not gone down, they don't feel as well. Dyspneic with exertion, those kinds of symptoms. And then obviously if you fail rate control. So as I said, there isn't any data yet for rhythm control improving outcomes such as stroke, so we're reserving it simply to improve quality of life. So how do we go about then choosing an agent or a therapy for rate control for atrial fibrillation? It really is fairly straightforward, and I'm sure you know all of this, based on their comorbidities, whether they can tolerate a beta blocker or a calcium channel blocker. Either one would be fine. Make sure that you're not using digoxin as a first-line agent. Digoxin is only for patients with heart failure and recurrent admissions for heart failure exacerbations. Amiodarone is also a very good rate control drug, and it can be used at the end of the line if other rate control approaches are failing. How much rate control do you use? It hasn't really been properly defined, and when we're looking at the trials that tried to study this best, even with lenient rate control, meaning a resting heart rate of less than 110, there was not really any big change in their hard endpoints. But by and large, heart rates of 90 and below, that would be sort of a reasonable practice, at least in our group. Heart failure patients, what do we do? Are they any different? Can we just go ahead with also a rate control versus a rhythm control approach? This was addressed in a large trial in the mid-2000s, and also there was no major difference in hard endpoints when the patients are randomized to an antiarrhythmic approach. There is some conceptual and animal data that shows that some ventricles are better off in regular rhythm. And this is regular rhythm, even if it's rate controlled. No one fully understands it, but even if you were to pace animals regularly versus irregularly, the ventricular function is worse with an irregular pacing strategy. So in some patients, worthwhile in practice to consider a rhythm control approach for your heart failure patient, just to see if the ejection fraction improves. We don't fully understand that mechanism, but if you don't see any benefit, it just makes more sense to go with a safer approach, which would be your AV nodal blocking agents. Important to avoid dronedarone in patients with heart failure. It increases mortality. So anyone with heart failure, you're obliged to avoid this medication. Digoxin, as I said, should not be first line, only should be reserved for recurrent admissions for heart failure. Remember that it does interact with these other two medications that can concomitantly be used in heart failure. Easy board question. So rhythm control in atrial fibrillation, how do we decide on that? And it really is based on the presence of structural heart disease. So if this is a normal heart, so the patient to picture here is your 61-year-old, no structural heart disease, normal size left atrium, highly symptomatic episodes. There's an option to move straight to ablation in these patients or move ahead with medication. So it's a class 1 to use these medications here, flecainide, propafenone, sotalol, even dronedarone here, or even ticasin, the dofetilide. Amiodarone is not a first-line medication. And then also a class 1, if drugs fail or the patient is uncomfortable using these medications because of their pro-arrhythmic potential. Atrial fibrillation does not cause sudden death. All of these medications can cause sudden death. Some patients would much rather take a medication than undergo a procedure, which has real risk, but it really becomes a sort of patient preference here. So fine to move ahead with ablation. And just to remind you, we're discussing patients with a normal heart who have paroxysmal symptomatic atrial fibrillation. The patients with persistent atrial fibrillation, as Dr. Madhavan showed, there's a lot of substrate abnormality there. Their left atria, generally when you get to a persistent form, are diseased, and we do not have good catheter-based approaches for persistent atrial fibrillation. So structural heart disease then is a different group, and breaking these into coronary disease or decreased left ventricular systolic function. Sotalol and ticasin are your go-to drugs, and they've been tested in this setting. It often comes up, can you use sotalol in patients with a reduced ejection fraction? It would be like starting any beta blocker in this group of patients. You do have to be careful if the ejection fraction is 20% and you want to use sotalol. It would be a little bit like carvedilol. You wouldn't start them out at 50 milligrams twice a day of carvedilol. I think reasonable to up-titrate any beta blocker because of its negative inotropism in someone with reduced left ventricular systolic function. If these were to fail, ablation is still an option, but as I mentioned, we do not have slam-dunk ablation approaches for patients with structural heart disease and diseased myocardium, disease substrate in the atria, which lead to sort of a substrate-based approach. We're not sure yet what the best approach is for these patients. Amiodarone is a very good fallback option for these patients. Dronedarone can be used in patients with coronary disease, but just remember, and it gets to the question I was asking earlier, it is contraindicated in patients with persistent atrial fibrillation. It's specifically for paroxysmal atrial fibrillation. It can be started outside of the hospital. You need to follow still the liver function tests in patients who are taking dronedarone, but this is not for someone with persistent AFib. It increased mortality. So no heart failure patients, no persistent AFib. So new onset atrial fibrillation and post-op atrial fibrillation, I think, are two unique categories which come up so frequently in practice. And there is some more recent data to guide us better as far as the post-op AFib is concerned. The guidelines came out just before this randomized trial came out, but I think they still echo the same sentiment. So in this randomized trial, after cardiac surgery, it was either a rhythm control approach or a rate control approach, and there was a difference in how many patients were in sinus rhythm at the end of 7 days when they were discharged from hospital. But there was no difference long-term in AFib admissions, hospitalization, or complications. And so this is more evidence that probably you should be using a rate control approach as your first-line strategy after cardiac surgery, where AFib is just such a common sequelae from the irritation, from the pericarditis, from the surgery itself. So post-surgical atrial fibrillation, the guidelines are saying reserve amiodarone or rhythm control approach only for the high-risk patient. But they hedge their bets on, or their description on what is high risk. So here I would say someone really is decompensating significantly when they go into atrial fibrillation. Then you've made a case that you've chosen a more risky strategy. You're choosing a medication with potential for more side effects, amiodarone, versus your AV nodal blocking agent. So each time this person goes into flutter, their blood pressure tanks, they can't do their rehab. Otherwise, beta blockade, calcium channel blockade should be your first go-to strategy. And I guess if these are post-bypass patients, as they were a lot in that trial, it should be a beta blocker. Anticoagulation, how long do you treat them for? We don't know, but generally our practice here has been at least 6 to 9 months and maybe longer based on their CHADS2 VAS score. But that really, we don't have enough data on that. But definitely there is a class 2 indication. If these patients go into AFib, you should anticoagulate them. So new atrial fibrillation, I'm not going to dwell on treating obstructive sleep apnea. I'm sure you all know it's there very often as a trigger for atrial fibrillation. There's good data from the ablation literature that if you treat obstructive sleep apnea versus not treat it, and that group of patients gets an ablation, those who had their sleep apnea treated are much less likely to have recurrent AFib. And that's even in the context of the best antiarrhythmic therapy that we have. Diet and exercise, I think, really has changed the landscape here. This is not something that was included in any of our recommendations 5 years ago, but the data is really, really powerful. And if you don't know it, you should look at some of these trials. Here, this is ablation-free, drug-free. So no other intervention for patients with paroxysmal atrial fibrillation, a large study out of Australia. And recurrence here is based on how much weight this group of patients was able to lose. So weight gain or losing less than 3%, you can see AFib is definitely coming back. And that's without any therapy. This is more profound. So this is patients, if we throw in everything, we throw in antiarrhythmic therapy with drugs and with ablation, this group of patients here didn't lose weight and didn't improve their exercise capacity above 2 METs. And you can see the recurrence rates of atrial fibrillation here in the 70% range. So only 30% of them were free of AFib. But this group here, we're in the 90% range for patients who rarely turned their life around. And we used an adjunctive antiarrhythmic strategy, ablation or drugs. So profound, profound differences. So really something to start discussing with your patients. We never thought that this sort of element was remedial, and it is remedial. There are enough triggers here that affect the autonomic nervous system for patients to get huge benefit from diet and exercise for atrial fibrillation. So an important one for practice, and easy to ask a couple of board questions on. What about the patient who is at risk of side effects or complications from their ablation procedure? Here's a case. So day 1, post-ablation, patient really was feeling fine, no shortness of breath, chest pain, ambulating. Generally at this stage, I just want to get out of the hospital. The echo, which we routinely use a day after the procedure, showed no effusion, good left atrial function, and maybe a little bit of extra fluid on board with a full IVC and reduced inspiratory collapse. Patient was still discharged. This is a cine from the procedure itself. A cryoballoon was used. You can see it here in the right inferior pulmonary vein. It's been used to occlude the vein. We've injected contrast into that vein. We've got a nice occlusion. And then ablation is performed through the balloon, ablating the atrial tissue outside of the venous ostium. So the ECG for the patient in question, sinus rhythm, no ST segment elevation, no acute changes. But then you get this call day 5. Dyspnea on exertion, doesn't have any P&D or orthopnea, no leg swelling, blood pressure and pulse is still good. So what's the most likely diagnosis for this patient? Fluid overload, phrenic palsy, tamponade, recurrent atrial flutter, or pulmonary vein stenosis. Can we vote on this, or should we just make it a rhetoric? So, good. So the majority of you were thinking of that. We'll speak specifically about pulmonary vein stenosis because it is something that you really mustn't miss. But just the time frame for phrenic nerve palsy and the fact that I showed you that cryoballoon stuffed into the right inferior pulmonary vein, you really have to start thinking about that. That's the main drawback with cryoballoon procedures. It's a much higher incidence of phrenic nerve injury with that procedure, and it's becoming really much more commonplace to be using a cryoballoon than to be using RF catheter ablation for paroxysmal atrial fibrillation. So here's the chest x-ray. You can see elevation of the right hemidiaphragm, and asymptomatic for most patients, not sure exactly why. Highly symptomatic in some patients, but usually it resolves. So just making sure that you're not missing anything, because if you look at the long-term complications or long-term outcomes or sequelae of phrenic nerve injury, most of these patients do very well. There are a few other places where we can injure the phrenic nerve. So if there's been ablation around the superior vena cava, we almost always would mark the phrenic nerve here on our map that we create. Here it's marked in a dangerous pink so that we don't ablate over it. We pace over the nerve to capture it. And if you look here a year out from the original cryoballoon studies, at 12 months, only one patient still had symptoms and most had resolved. So important to just recognize that it is going to resolve and that you're not missing anything else. So dyspnea after ablation is a worrying thing. There really shouldn't be shortness of breath. It may be that it's just volume overload, or there's some segmental atelectasis because general anesthesia is common and they can be long procedures. But these are the three big ones to make sure that your patient does not have. And very often it's not us as the electrophysiologist who catches this. It's that we've done an ablation here, the patient is now back home in Nebraska, and we get a call from either the patient or usually the general cardiologist or the internal medicine specialist who's dealing with the patient with one of these issues. So pulmonary vein stenosis was a big issue in the early 90s when ablation was starting. You can see just over a 3 or 4 year time frame, it reduced enormously because we realized that if you were ablating inside the pulmonary veins, you were injuring the venous tissue and it would stenose. So ablation has to occur in the atrium. We have to ablate atrial tissue to avoid this, and that's standard procedure these days. We shouldn't be ablating in the veins, so it's much, much less. It's still real here. You can see in the CT scan just this narrowed vein that progresses over time. And what patients develop symptoms, it's usually patients who occlude more than one vein. So just one vein, and we don't see it that often. Here you can see the number of affected veins, and then symptoms go up. Here you can see stenting. Angioplasty and stenting has become standard for these patients, so it shouldn't be missed because the end results can be good. How do they present? It really is shortness of breath, dyspnea and exertion, cough. I find hemoptysis is really quite common. We routinely monitor our patients with a 3-month post-ablation CT. I know that it's not standard practice around the country, and even though the guidelines allude to that and see it as good practice, it's not mandatory. But we would call all pulmonary symptoms as they're developing and getting worse over time by that 3-month follow-up visit. We would say this is pulmonary vein stenosis until we've confirmed it otherwise. The arrhythmias are common after ablation. You can see here these red dots from one of our electroanatomic maps. Each dot is an ablation point. Each dot has caused injury, and each dot has caused inflammation, and there's going to be healing. Very, very common to have AFib, atrial tach, atrial flutter, just as the heart is healing from the procedure. We feel that it's sort of maladaptive from an electrical perspective, and so if patients develop post-operative atrial arrhythmias, we should treat them. Even though it's commonplace, we still treat them, and then we can revise that decision at 3 months or maybe even later to stop the antiarrhythmic therapy. Tamponade is by far the most common serious complication that occurs at the time of the procedure. And for us, with intracardiac echo in the heart, we have sort of a head start, and it's very uncommon for this type of tamponade to lead to a catastrophic endpoint, because we can get in there and tap it very quickly. But it is important for you guys to know that all that irritation around the heart from ablation can result in late effusions in patients. They exist, and it's really sort of a pericarditic as opposed to a perforation-related tamponade that develops from an effusion. So in summary then, the atrial arrhythmias are common in those first 3 months, and we definitely want to treat them. You don't want to let that go missed. We usually say anything lasting more than 24 hours, they need to let us know, and we should treat those. There's good data that if you treat them, there's less late recurrence. Dyspnea is a bad deal. Always investigate that. Atrioesophageal fistula. Here you can see the left inferior pulmonary vein. You can see the esophagus sitting right here. Here you can see some air in it. It's our sort of most feared complication. Injury to the back of the esophagus is lying right there, is common with cryoballoon or RF. Sorry, not common, uncommon. But it's something that you really need to be worried about. So the incidence is very small, but something that I would take seriously in any patient presenting strangely. So the patients that we've seen coming in with this kind of complication, no one really knew what was going on. They were really confused. They were sort of intermittent, fluctuating fevers, decreased sensorium. Esophageal symptoms are very often there, but it's this sort of embolization of gastric contents into the blood that's going to the brain that's really causing fever and this sort of affecting their sensorium. So anyone presenting strangely after an ablation, you really have to worry about this. It's very often catastrophic and presenting sort of late enough that the treatment is too late to save the patient's life. But definitely it can be treated successfully, and this is the thing to know in practice and for the boards. You really want to avoid endoscopy in these patients. So CT, MR, something non-invasive, and even a barium swallow where you can see this beaking occurring behind the heart, those are reasonable. But don't go sticking a probe down there, because as soon as they insufflate and put air into the esophagus, they're going to put that into the heart, and it can be fatal. Okay? So let's wrap up here. Know the acute and chronic management of the SVTs as we went over. You can read through sort of those guideline statements. Always cardiovert the patient if unstable, or if they're not responding to adenosine or other AV nodal blocking agents. Ablation really is first line in many of the SVTs, if not all. Know when to risk stratify the WPW patients. It's on whether you think that pathway is potentially able to conduct quickly and result in VF. Don't block the AV node at all in someone with pre-excitation. Dyspnea should always be investigated and avoid that endoscopic probe if you're worried about atrioesophageal fistula. Amiodarone, never a first-line agent, and so that question was a difficult one for earlier, but also know that dronedarone has these limitations of heart failure and persistent AF. Remember that class 1C drugs, those are for patients with normal hearts. Any scar in the ventricle for someone who has hypertrophic cardiomyopathy or some kind of myocardial infarction, those scars can precipitate reentrant VT, so avoid those drugs in patients with structural heart disease, so it's sotalol or dofetilide. Thanks very much for your attention. Thanks, Steve.
All right, thank you very much, Chris. We'll go to your questions here. So the first one is the 19-year-old asymptomatic male for further evaluation of a baseline ECG which shows intermittent pre-excitation at a heart rate of 57. What is the preferred approach? An EP study to risk stratify, start beta blocker, exercise stress test, a Holter monitor, or simple reassurance? Okay.
Good. So the fact that there is intermittent pre-excitation at a low heart rate means that this is not a robust accessory pathway. It means that it's blocking, so there's intermittent pre-excitation. And if it's blocking at such a slow heart rate, it's never going to conduct quickly at rapid heart rates. And that's the only worry with WPW or with pre-excited ECGs. You don't want atrial fibrillation to conduct quickly down the accessory pathway. Here you have enough information to say this is a pathetic accessory pathway. It can't even conduct at 57 beats per minute. It's never going to conduct at AFib rates, and that's your only worry.
So an intermittent pathway never becomes more robust under catecholamines like with exercise or those kind of things.
Exactly. It's different from the AV node. AV node will function so much better with catecholamines. If this thing is blocking, that's why an exercise test, that's why a Holter. If you don't have enough clarity on the conduction properties of that accessory pathway.
So it's just pathetic. All right. Do you put that in the chart?
Pathetic accessory pathway.
Leave
That's
it
the
alone.
diagnosis.
All right. Next question is the atrioesophageal fistula question. Which of the following is true regarding these fistula? They occur right away within the first 24 hours. It can occur on day 3 as a peak, happens 1 to 4 weeks after the procedure, 3 months after the procedure, or at any time.
Great. So yeah, I think it is important to know when these catastrophic complications can present, and that's always on everyone's radar in those first 1 to 4 weeks after an ablation. If someone is presenting confused and febrile with any kind of esophageal or odynophagia, any esophageal symptoms, that has to be right high up on your differential and move to a non-invasive imaging modality.
So you don't put a TE probe in. All right. Next question. Which of the following antiarrhythmic approaches should be avoided in a 59-year-old woman with no structural heart disease and persistent symptomatic AFib? Amiodarone, flecainide, dronedarone, or propafenone?
Yeah, I think that you both are correct. You shouldn't really be using amiodarone as a first-line agent. Dronedarone, making sure you're aware, because the patient has persistent atrial arrhythmias, there's a higher incidence of death in those groups of patients in that trial. So that's a black box warning, class 3 indication. Persistent atrial fibrillation and patients with heart failure should not be treated with dronedarone.
So there's a couple of questions about whether that heart failure contraindication persists in cases where the heart failure has a reversible cause. So they had a low EF for some reason that is now resolved. It could be peripartum, it could be alcohol-induced or tachycardia-induced, it could be someone who now has a BiV pacer and their EF is normalized. If they've had a history of AFib, but now of low EF, and now their EF is normal and they don't have heart failure symptoms, can you use dronedarone in those cases?
I think that's reasonable if there's a reversible cause. The thing to be careful of, though, if it's a tachycardia-mediated cardiomyopathy, then they must have had persistent atrial fibrillation. And if someone has persistent atrial fibrillation, then they have the substrate for more persistent atrial fibrillation. It's not a triggered event from the pulmonary veins, and I would be careful with it. In practice, dronedarone is a little bit like the accessory pathway. It's a little on the pathetic side. It's very rare that I see sort of landmark changes in someone's atrial fibrillation management using the medication. I would think of it as safe to start outside of the hospital. It's not as effective as flecainide, propafenone, sotalol, or ticasin. Definitely not as effective as amiodarone. And so I guess it's worth considering, but I've never seen, we don't use a lot of it, and that would be our entire group.
Okay. Melanie talked about anticoagulation in hypertrophic cardiomyopathy patients with SVT, but what is your preferred first-line agent? We used to use amiodarone out of the box for so many of the patients, but your last slide said never consider amio as a first-line statement. So how do you treat a hypertroph who is presenting with symptomatic AFib?
Yeah, hypertrophs are different. The first thing to recognize is this difference between their type of atrial fibrillation and sort of the paroxysmal AFib patient. And so the paroxysmal atrial fibrillation patient triggered pulmonary vein activity that's starting things, and those triggered pulmonary veins very often are sensitive to the class 1 drugs. So flecainide and propafenone are very often my go-to medications. But the hypertroph, if you look microscopically at their heart, there's fibrosis in and around that heart. So this could be a 31-year-old with paroxysmal atrial fibrillation. But with the hypertrophy, with the hypertrophic element, the fibrosis makes it more likely for reentrant ventricular arrhythmias if you use a class 1 drug. So that's the first thing, is just to stay away from the class 1 drugs. I was sort of alluding to it. These are patients with structural heart disease, and even though they're young, you're going to have to more than likely use a class 3 agent. And so sotalol and Tecousin, those are the two I mainly go to.
And you're not worried about QT prolongation?
The QT prolongation you have to be careful of, because very often the QRS is a little abnormal. Very often there's a left bundle. You really have to be careful to monitor it quickly.
And repolarization is abnormal in these thick hearts so often.
Exactly.
Yeah.
Exactly. Do we have any data that they're at more risk of torsades? We don't. But I agree, you very often see these very bizarre T waves, and so tough to get a good QT measurement. Yeah.
And if they get prolongation of the QT, does the presence of a defibrillator make you more comfortable with that? You know, allowing a little bit higher QT than when you would in someone who doesn't have a prophylactic device in place?
So in practice, yes. So if someone has a defibrillator, I'm far more lenient with how much QT prolongation I'm willing to accept. So we can discuss numbers if you want afterwards, but I am definitely less careful as which you want to suppress their atrial fibrillation. The other drug that comes up not infrequently with hypertrophic cardiomyopathy and atrial fibrillation is Norpace. I'm blanking on disopyramide. I'm yet to prescribe disopyramide, and I think of it more as a toxin, but it is there is an indication for disopyramide and atrial fibrillation, and it's those patients with hypertrophic cardiomyopathy.
Yep. And we do use disopyramide, as we said the other day, as kind of a second or third line negative inotropic agent to help minimize the impact of outflow tract obstruction. So definitely I have taken someone who maybe has PAF and they've still got symptomatic outflow tract obstruction and chosen disopyramide as their antiarrhythmic drug therapy just to see if we get double benefit for that. Have I been impressed that it's been highly effective? Hard to say.
Yeah, usually those patients are headed to ablation, I have to say. And the ablation results are reasonable. It's just such diastolic restriction. The left atria are usually very abnormal, and it's a more complex ablation strategy.